Yeah, can we start? Okay. A very good evening to all distinguished colleagues. I'm Dr. Samir Muchala, heading the medical affairs for the cardiology and diabetology therapy areas at Zydus Healthcare Limited. At the outset, I'm sure you and your loved ones are safe and healthy during this current trying times. It gives us immense pleasure to invite each one of you today to our live webinar in the form of a panel discussion on hypertension management holistic approach. The World Hypertension League is observing a makeshift World Hypertension Day today due to the ongoing COVID crisis. World Hypertension Day was initiated in 2005 to raise awareness about this hypertension disease as a silent killer and its impact on cardiovascular disease and possible responsible for premature deaths worldwide. Hypertension is consistently related to development of ischemic heart disease, heart failure, stroke, and chronic kidney disease. An estimated 57% of stroke-related deaths and 24% of coronary artery disease-related deaths are attributable to hypertension. India is plagued by an hypertension epidemic, which is complicated by low awareness of the disease and poor blood pressure control. This warrants a holistic understanding of the management of hypertension, along with recent developments in this dynamically changing therapy area. To enlighten us more on this today evening, we have an elite panel of cardiologists having international repute. It is my honor and privilege to introduce our moderator for the evening, Dr. Brian Pinto, who requires no introduction. Dr. Brian Pinto is Chief of Cardiology and Director, Cardiac Catheterization Laboratory at the Holy Family Hospital, Mumbai. He is recipient of the Inspirational Cardiologist of the Year by Economic Times in 2020. He is teacher for DNB cardiology students for more than 15 years. He is pioneer in transradial interventions and rotational atherectomy in India. He is Secretary General, Indian International Forum of Cardiology, IIFC. He's a top cardiologist by the Outlook magazine since the last 5 years, and he has various publications in reputed journals. I welcome Dr. Brian Pinto and request him to take the academic proceedings forward. Thank you.
Thank you, Samir, and welcome to all my, my colleagues. All of them actually very renowned cardiologists, very renowned in the field of hypertension, and certainly good evening to all of you. And we start today with with the proceedings. Tiny, I can see you there. Welcome. Then Soumitra, Venkatesh, all of you welcome, and let's hope we have a great discussion today on this the World Hypertension Day, the 17th of October, 2020. So let me share screen with you.
It's and 20 hours.
I don't know whether Samir, you're going to share screen or I will share screen.
If the CV slides are there, I have it with me.
I also have it. Let me just see if I can share screen, and then if that's possible, I'll do it. Otherwise, I'll ask you.
Sure.
I think I should be able to. Just give me a minute. Yeah. Okay. So here it is. Are we going to be living longer by controlling our blood pressure? Most of us know that what the ESC said, in 2018 in the ESC, what they said was that if you were to have to control 2 risk factors, what would you do? The 2 risk factors that you should control are the hypertension and lipids. If you did that, you would reduce mortality by more than 90% for cardiovascular events. If I were to throw my money into something, where would I throw it? Where would I ask people to do things better? One is in the area of hypertension, because all of us know it's a low lying fruit. It's a very low lying fruit, actually, can be picked up very easily. You just need a good blood pressure apparatus, one that is validated. You need to check properly. And the second thing that we would like to do is basically to see that it is controlled properly. And if you control lipids as well, I think vascular disease per se in countries like ours will get significantly controlled. And here is the status that we go through. Look at the prevalence in our country. It's so high. Even in people above the age of 25 or 30, if you were to take the whole population, almost 40% of patients people would have blood pressure. Now, that blood pressure would depend upon where we want to measure it at what level. As you can see, more than 11 or 12% of deaths occur because of hypertension. The urban population has it, the rural population has it. The awareness is poor both in urban as well as in rural population. And the control levels are abysmal, actually. So clearly, to all of you, all of you know, this is an area where we would need to get into the details of how we can fare better. And for that, we need a call to action. So let me start with my good friend, Shaumitra, and ask him. Shaumitra has been part of the CSI, has been part of various hypertensive kind of approaches. And, I have not introduced all my panelists right now, but I'm going to introduce them as I take that question. So let me first introduce Shaumitra Kumar as I take up this question and talk about him a little bit. So if you can share with me the slide on Dr. Shaumitra Kumar, Samir, I would just first like to introduce him before I take up this issue. And I will introduce each of the panelists as I bring them up, because I think that would be a better way to do it. Can you share your slide with me,
Yeah,
Samir?
so you need to stop sharing your screen so that.
So let me just stop sharing the screen over here and, bring us to Shaumitra. Let us introduce him a bit. He doesn't need any introduction. He has been part of our, cardiology community for more than 25 years, uh, you know, and yeah, so he's been the professor and the head of department at the Vivekananda Institute. I think you've got my screen. You've shared me again. I think you need to go to Shaumitra. He's the chief coordinator for the academic services that we have at the Rabindranath Tagore Institute of Cardiac Sciences in Kolkata. He's the consultant cardiologist at Fortis Hospital. He's the past honorary secretary of the CSI, where I was very closely associated with him, and where we did a lot of work together. He's the president of the Indian Academy of Echocardiography in West Bengal and the Academy of Echocardiography, as you can see. And he has more than 150 publications, both in the international and in the national journals. And there's nobody better than Shaumitra to be on this particular panel. And so let me go back to sharing the screen, or and tell you and ask Shaumitra, what would be the best strategy that we would need to work with in India to manage the burden of hypertension? There are 3 points that are put up over here. Maybe we would say all 3 of them, and Shaumitra can take us. This is a question that the delegates will have to answer. Shaumitra, you have approximately 3 to 4 minutes to talk to us about this, and then we will take up a vote from the delegates. Please go ahead, Shaumitra.
Okay, thank you, Dr. Brian, for the kind introduction and strategy that works best in India. So, what is special about India? I mean, a quick word about that. On one hand, we have a relatively weak health system. I mean, blame it on anything starting from political apathy to bureaucratic inertia to the size of the country, its diversity. We have a relatively weak health system, and against that, we have a overburdened healthcare. Uh, I mean, system as such, because we as providers are overburdened with the patient population that we deal with everyday practice. And our patients, I mean, many of them, as you have shown that the awareness about hypertension in rural India is very high. almost over 40%. So illiteracy, poverty are problems with our patients, and they are unempowered to a great extent. So in this background, what should be the best strategy for control of hypertension in this country? So of course, health education and education as such and health education. We need to impress upon the patients that hypertension is a lifelong disease. So either you control hypertension to live long, or hypertension takes control of your life and terminates it early. So that is the basic education we have to spread. So the importance of controlling hypertension. And then, of course, diagnosis is a big problem because many people, hypertension being a relatively asymptomatic disease, many people are unaware of their hypertension, despite the fact they may be having a significant stage 2, stage 3 hypertension. So we need to lose no opportunity to screen our population almost, at every instance, be it blood donation camps or pre-employment checkups, whatever. Just to name a few. So screening a population whenever you are given a chance is the best way. A patient visiting the hospital to any department, dental department, eye department, screen them for simple blood pressure measurement. So another thing is screening of the population. Then once you have diagnosed hypertension, when it comes to the management, of course, what should be the initial therapy? Now we have more or less decided that except for the very elderly and frail patients, we start with a combination pill of two drugs. So that should be cheap, that should be widely available. So these are the things, and if possible, it should be given free at the primary healthcare level in the rural sector at least. So that is initiation of therapy. Then the major problem is with maintenance of therapy and adherence to a prescribed regimen. So with regard to that, first of all, health education again here is very important, and you have to be in touch with the patients. And here telemedicine and other modalities come in handy. The use of home blood pressure monitoring. So the devices should be more reliable, more validated, and they should be affordable again. So ultimately, these are the three sectors: diagnosis, initiation of therapy, and then adherence, and ultimately follow-up of the patient. So I think these things, I don't know whether I've crossed my time limit or not, but I think these are the major points.
Thank you, Soumitra. I think you covered a lot of the aspects, the health education, awareness, the ability at various camps to do this kind of work. Telemedicine you brought in. You also brought in, most of the data that we need to have, and see into what kind of things we need to do. So let me then ask, the discussion from this discussion. Samir, have we had the polling done already, or we'll give a minute from over here for the polling to occur?
No, we have the polling done,
Okay.
and 69% of the delegates suggest health education awareness, 15% suggest screening of population, and 15% suggest appropriate management of hypertension in India. That's the poll results.
So it looks like, health education is something which most of our people feel, and I kind of agree that health education, but I think, even screening, if you remember, Polter recently in the UK, Nick Polter had a, hypertensive month, last year, or was it in 2018? It was a hypertensive. So everybody was screening about 100 patients every day in their clinics, and they had more than certain amount. So I think health education is definitely very important, but screening of population, if we take it up very seriously, then also becomes an extremely important part. And appropriate management you cannot overemphasize. So I think all three are important, but health education certainly looks like is a very important part. So the next point is we are going to talk about is the evidence for the universal blood pressure goal. And I'm going to, say that after the sprint evidence, those sprints said that in 120 by 80 or less, but this was measured by a very, very, very unique method whereby patients were kept in a room, dark, no nurse, no doctor, three readings done, and the patient was not in a usual kind of setup where they tell us to measure blood pressure. Okay, keep him for 5 minutes in your room, then measure it once or twice, two times. Patient sitting in an adequately rested position, but the nurse or the doctor being there. So I think the sprint of 120 by 80 may be equivalent to a 135 by 85 of other measurements of blood pressure or something like that. So clearly the evidence strongly supports bringing blood pressure down to less than 130 by 80. That is clear, because sprint showed that when you brought blood pressure down, you had less events, except stroke actually was not so much less. It may have gone up a bit. But here we have Venkatesh, Dr. Venkatesh, whom we are going to, ask about this. But before I ask him the question, I'm going to introduce him. So can Samir, once again, we stop sharing screen over here, and you please bring up the slide of Dr. T.K. Venkatesh. So I'm introducing every speaker before the question that is put up to him. So can you do that for me, please, Samir? So here is you sharing Dr. Saumitra's, yeah. So here is Professor Venkatesh, who is a friend of mine from Bengaluru. He is the senior consultant interventional cardiologist at the Apollo Hospital, and also the president of the Karnataka chapter for the Cardiology Society of India. He's also been the ex-vice president. He's been a permanent member for the research committee of the CSI, and he's also been in the echocardiographic committee for the Indian Academy of Echocardiography. And I think we were together for the Lipid Association of India. So, welcome, Dr. Professor Venkatesh. And the question to you, let me share screen once again, as you can see. Samir, can you get us back to, so that I can ask that question properly and not make a mess of it. So what would be the objective, for the management of hypertension? And this is a question which I think is very important. I think, I have clearly looked at it, that just managing blood pressure may not be the only answer. We must look beyond it. Just a number I don't think is sufficient. And we are all looking to, so is it to control blood pressure alone? Is it to reduce long-term CV events? Or is it to avoid hypertension-mediated organ damage? Venkatesh, you have 4 minutes from here. Please go ahead and give us your insights into this question.
Thank you, sir. Thank you very much for those kind words of introduction. First of all, it all depends upon how we look at blood pressure, elevated blood pressure. There are various ways of looking at it. One is to look at it as a sign to monitor the patient's clinical status, or view elevated blood pressure as a risk factor for an atherosclerotic cardiovascular disease, or as a disease and a major contributor to death from cardiac, cerebrovascular, and renal and peripheral vascular disease. So we should not be just looking at hypertension as pure numbers, although they are important, but they carry a more important ramification. We should always remember that hypertension is a vascular disease, and when you have a raised blood pressure, it's associated with multiple comorbidities and multiple risk factors. It has been shown that when the BP levels are high, the incidence of cardiometabolic abnormalities also increase. So it's important to focus on the multiple risk factors as well when we are trying to treat any hypertension. Dyslipidemia or diabetes are just few examples where we have these comorbidities going on. It's also very important to understand and remember that the major part of excess mortality in hypertension is due to mild hypertension. This looks very surprising because all these years we have been used to a mechanistic view of hypertension. There are many studies, including a large study from Japan, which clearly shows that patients with hypertension of a systolic blood pressure of 160 and less had more strokes than patients who had a systolic blood pressure of 180 and less. So we should not be thinking of hypertension purely as a mechanistic complication of blood pressure. We should always remember the other cardiometabolic and vascular factors which are always associated with hypertension. And therefore, we should have a population strategy to reduce blood pressure, and we should make sure that we take the entire cardiometabolic spectrum into consideration before initiating treatment for hypertension. Thank you.
I think Venkatesh, you gave us a real good explanation to what we, looking at. You said that we just don't look at a number; we look beyond the number. We're going to look to avoid, long-term complications, and we are also going to look at, cardiometabolic, cardiovascular events. So, Samir, before we discuss a little further, have you got the poll results already, or we need to wait for a minute or so?
We have got the results. 29% suggest to control blood pressure only. 35% each suggest to reduce long-term CV events or to avoid hypertension-mediated organ damage. That's the poll results.
Okay. So, we can, I think we have a little time over here. So let me ask, Tiny Nair, though he is not on this question per se, what is his kind of view to this particular question? Tiny, can you come in?
Yeah, sure. The point is that option B and C look so very similar.
Yeah.
What Professor Venkatesh said is very right. That, for example, if we take a patient who does not, let's say 40-year-old doesn't have anything at all, we call him a simple hypertensive, right? In that hypertensive, you use any drug, ARB, ACE inhibitor, beta blocker, calcium antagonist, diuretic, bring down his blood pressure to goal, he becomes fine. So in him, it is just the number. But consider a person who has any additional risk factor, maybe diabetes, dyslipidemia, smoking, family history. Consider a hypertensive who has any target organ damage, that ventricular hypertrophy, retinopathy, kidney, anything. Consider one who has multiple comorbidities, liver disease, COPDs, anything. This patient with comorbidity, risk factor, and of course target organ damage, he has a totally different outcome. So obviously we are today not looking at the number at all. We are looking at the entire patient and how to reduce his global cardiovascular risk.
Correct. Correct. So therefore, look at reducing global cardiovascular risk would be the answer, in my opinion. That number and global cardiovascular risk are both important. And, if you can reduce ventricular hypertrophy, or if you could, reduce his GLS today, either reduce or increase, or however you look at it, you want to reduce, some kind of risk factor. You can reduce his microalbuminuria, which is there, whichever way, kidney, as you said. Clearly that we are looking at all these factors apart from just the number. So, I think, we are all looking towards the reducing long-term CV events, avoiding hypertension-mediated organ damage, and of course, controlling blood pressure. So all three are important. I would say everything is important, but every patient is different. So these are the insights into home blood pressure monitoring. We have not been a country that has really taken up home blood pressure monitoring in a big way. I think only few physicians in our country actually suggest home blood pressure monitoring. And there are two aspects which are clearly missed by just doing office blood pressure. One is, of course, the white coat hypertension, and the second is the masked hypertension. We can see very often that a patient comes to our clinic as a normal blood pressure, and at home his blood pressure may be much higher. It's important for us to go beyond this. Only certain regions of Asia, for example, Japan, Indonesia, and China, seem to have implemented this in a more comprehensive manner. And I think the guidelines are now beginning to bring in home blood pressure monitoring very clearly into areas of hypertension. These are the potential areas where the home blood pressure monitoring is coming in. And we have to possibly increase our insights for this particular area, where we can compare home blood pressure monitoring, ABPM, office blood pressure, various kind of. But unfortunately, the guidelines have not been as strict, though they have brought them in recently, have not been as robust for home blood pressure monitoring. And here is where I would like to bring in. You can see in this slide over here that there are guidelines in China, published local guidelines, published local home blood pressure monitoring guidelines, where we have only in China, Indonesia, and Japan. And I would like an action to be brought in by Tiny over here. What are the best ways in which we could approach this home-based blood pressure monitoring? Is it through better patient education, improved access to monitors, improved standardization? Of course, all of the above may be the point. But Tiny, what do you think about this home blood pressure monitoring, and how do we go about it?
Can we introduce Dr. Tiny Nair?
I forgot. So sorry. So sorry. Tiny is so well known. And thank you for that. Can we share screen first?
Sure.
So Tiny is a great friend of mine. Whenever I see him, it's always a pleasure. It's a great pleasure to see him because he is an embodiment of great knowledge. He's such an embodiment of knowledge that he always brings to us some of the greatest articles are actually brought out by Tiny in this area of the world. And I'm very respectful of the data that he has presented to us over a period of time. He is the head of the Department of Cardiology at the PRS Hospital in Trivandrum. His publications are immense, and they are not in small journals. It's in Nature. Anybody who gets, I don't want to talk about JSCC because it's a great journal, but I love to talk about Nature. If anybody gets a publication into Nature, he should be looked upon differently. And Tiny is one of those guys. He has got books and national orations to his credit. He's on the editorial board, not only of the Indian editorial board, but also of the European Journal. He has been the best reviewer award for the Annals of Internal Medicine in 2019. He's got the best doctor award from the Economic Times in 2019 for the most inspirational doctor. He's got the award from the government of Kerala way back in 2003. And once again, a newspaper which I truly revere as one of the good newspapers, the Hindu, is where he writes very regularly. So Tiny, over to you, and let's have your view on this aspect of home blood pressure monitoring.
Yeah, thank you, Dr. Brian. Home blood pressure monitor is a pet subject, and we are way into it. So I think people should all realize that hospital, especially in India, is not a nice place at all. We know that the hospital doesn't smell nice, doesn't sound nice, the ambience is not good. Nobody likes it. The moment a person, even doctors, we enter a hospital, we are stressed up. So hospital clinic in India is not a good place to record blood pressure because the patient is angry, hungry, upset, stressed, and everything. Right. So we need to take blood pressure measurement out of the clinic. And how we can do that? We can do it by an ambulatory BP monitor, which is tied onto the patient and it records blood pressure for 24 hours, but it is expensive. The other cheaper method would be that there's a blood pressure instrument. The patient puts it at a particular time and it automatically records the blood pressure. And most of these new blood pressure, home blood pressure apparatus has an algorithm. It inflates, deflates, doesn't show anything, but records the first numbers, gives a 30-second gap, again inflates, deflates, and then again 30-second gap, and the third inflation, deflation. And then the algorithm averages the last two and shows the report. Either it shows it or it keeps it in the memory. And a week later, when the patient comes in, we hook into the system and we get his blood pressure. Home blood pressure is one of the safest things to do. And like Dr. Brian Peter just now said, it will tell us about white coat hypertension, masked hypertension, so many other things. Now, one common question is, do we do it for everyone? It's simply not possible. It's not just the cost of the apparatus, not just the cost of the ambulatory BP. Even if you take that the home BP, it involves a lot of training and teaching in your time, right? You have to go and tell the patient how to do it, how carefully to do it, in what posture to do it. You should be careful how to do it, record all that, bring it back. Don't put that instrument into water and all that. In India, such things happen. So the point is, whom should you do it? So we always say, if you find a dichotomy between your patient's blood pressure and his target organ damage, do a home blood pressure monitor. For example, you see a person's blood pressure is very high, but his eyes are normal, retina is normal, no left ventricular hypertrophy, no kidney damage, nothing. So you suspect, can it be a white coat? Maybe he's upset. In contrast, you find somebody who has the features of left ventricular hypertrophy and strain, but your blood pressure is showing what? 140 over 92. Again, dichotomy, peripheral target organ damage, but his blood pressure is not very high. Do a home blood pressure because he might have something like a masked hypertension. Okay, so when there is a dichotomy, do it. When your blood pressure is not getting controlled on standard drugs, do it. If you're not sure whether the person has a high blood pressure or not, do it. So there are a lot of indications. They're not going to that. But I think the point is very clear. We need to have a very clear guideline in India as to telling our physicians when to do, how to do, and how to interpret a home blood pressure. And obviously the question answer is, it's like giving away the question before the answer is put. And I give the forum back to Dr. Brian Pinto.
Thank you, Tiny. You gave us a good idea about this dichotomy where we should do home blood pressure monitoring. And I think, it's not easy to do, as you said. Somebody may put the instrument in water also. So really need to teach them. You got to do recordings over 7 days. Then you have to, first day recording has to be taken away. Then the remaining 6 days recordings, usually taken in the morning time between 6 o'clock and 9 o'clock. Then you have it recorded. And actually, it has to be done on instruments that do not show the patient the blood pressure, because otherwise he'll get upset. He has to come back to you and you should be able to see the blood pressure. So all these things are there and they have to be done on machines that are validated. There are lots of machines that are not validated. So clearly it is not only a matter of doing it, but it's a matter of doing it well, which is important. So let's take, Samir, can you tell us the poll has come in and what it looks like?
50% of the delegates have chosen the last option, which is all of the above. 38% think it should be better patient education, and around 11% think improved standardization.
But I think, you should have added one more, better doctor education also,
Okay.
Yeah, it's important because, who is going to suggest it? The patient cannot, poor fellow, suggest it that I'll do home blood pressure monitoring. He may buy a blood pressure monitor and not know how to do it. So I think better doctor education also important out over there. And I would want, maybe Venkatesh or Saumitra or, anybody to tell me how often they are doing this home blood pressure monitoring. I know, what about you, Tiny? You can tell us how often you get it done in maybe your patients?
Uh, we do it quite often, and like we said, COVID also had some good things that has taught us. Like COVID has taught us how to manage angina medically. So now today we tell a lot of patients, please don't come, do an home blood pressure monitor. And if they can afford to buy one, we tell them what to buy and how to buy.
Yes.
But
Yes.
then we have an enormous experience. We did the Indian Heart Study where we had
Yes.
18,000 patients, one of the largest database on home blood pressure monitor. And we found that about 15% has white coat hypertension, 19% has got masked hypertension. So I
Yeah.
think we do it quite often now.
Yeah. It's very important actually, and we have to do it over 7 days. No, we need seven days readings. No, for home blood pressure monitoring.
1 week, yeah, correct.
1 week. Yes.
But then the algorithm does all that, eliminating first day, eliminating the first of the three.
Correct.
The algorithm does all that. The moment you plug in, it just gives you the result.
Absolutely. So that's important. And what would be the just for the sake of the people who are the delegates that day, what would be the office blood pressure compared to the home blood pressure for normalcy? What would you say would be the normal home blood pressure reading?
The moment a patient comes out of the hospital, it drops by 5 millimeters instantly. Okay. Let us say if you take 140 over 90 is your cutoff for declaring blood pressure, it straight away goes to 135 over 85 the moment he is out of the office. So whether you are looking at an out of office blood pressure or home blood pressure, out of office means you can just ask him
Right.
to wait outside and do it sometimes later,
Yes.
or at home, it comes down to 135 over 85. And of course, if you're doing an ambulatory blood pressure, is different. The night blood pressure, which is the most sensitive, would go as low as 120 by 70 millimeters mercury.
Correct.
And if you actually take any one single parameter, probably that night BP is the most predictive of cardiovascular events.
I think night blood pressure is such an important, monitor for the cardiovascular events. And cardiovascular events, actually, if you were to take the night blood pressure, I think it would correlate most frequently with cardiovascular events. And unfortunately, other than the ambulatory blood pressure monitoring, I don't think any other blood pressure monitoring can give you that kind of detail. So I think we need to understand that. Now here is the hypertension in rural India and the contribution of the socio-economic position, where we can see that Bihar looks like Nigeria and Kerala looks like Brazil. So Tiny, I all really like Brazil, but that is how they say over here, that this is from the Journal of the American Heart Association, and maybe Muchala wants to tell us a little bit more about this. But the greater the income, there is the greater risk of hypertension. But I see it in a lower socioeconomic group also. There's no evidence that the educational attainment actually modifies the association between income, and education does not ameliorate the risk of hypertension in rural India. This is very clear. And even in urban India, I would not think that it has changed so much. I think people may take a blood pressure drug and still it's not very well controlled. And here is the data from the elderly, the health in India, reflection from the 75th round national sample survey, once again showing that the blood pressure is a pretty high risk factor and causes a lot of problems besides infections and other things. The hypertension is one of the important risk factors. So here is the question for Rishi, my good friend from Lucknow. So let me introduce Rishi first. Rishi is one of those guys who's not only, let me, get share screen with me, Muchala, please now again. Rishi is not only a guy who does cardiology, he's also a very good singer. And he's at the King George Hospital. He's been there doing lots of cases. He's FESC and FRCP from Edinburgh. He's the professor at the King George's Medical University. He's got many awards. He's got many big papers. He's been awarded the PC Didwania CSI Preventive Cardiology Award. He's got the Young Investigator Gold Medal. He's very, very, prominent in interventional cardiology. He's been in 15 large impact clinical trials, and he is all over. We see him in many, many places. He's been nominated for the Senate in the IIT Kanpur, which I think is a very prestigious kind of nomination. And so, Rishi, I am, pleased to have you on screen over here, but it's also my pleasure to ask you this question. And the question goes that, what do you think, do socio-economic factors and the age make a difference in our treatment strategy? These are with the various, points that have been put up, so the delegates can go and answer over time after they listen to Rishi. So what is your take on this question?
So thank you, sir. Likewise, it's always a pleasure to interact with you, and today evening is similar. Regarding this question, I would go with option number A here, although I would have been much happier if we had not used the term strongly, because there's nothing like an agree. It's like either strongly agree or disagree or something like that. Why I say this is because different antihypertensive medications have got different volume of data in terms of prevention of one or the other of the components of MACE, of adverse cardiovascular outcomes and cerebrovascular outcomes, as we may call it. Like, whereas calcium channel blockers and diuretics would be much more effective in preventing strokes in elderly. It would be for heart failure prevention, it would be diuretics and ACE inhibitors. For prevention of cardiovascular mortality in somebody who's at a high risk for cardiovascular mortality, it would be an ACE inhibitor probably. So we know that there are different medication that we use in hypertension, apart from controlling blood pressure, have got little bit slightly different volume of data in prevention of different cardiovascular outcomes. So when we take a look at the patient as a whole, and as was being discussed by Dr. Nair and Dr. Venkatesh, we have to take a look at the patient in a holistic manner. And if we take age as that factor, we know that if a person who is, a younger in age group person, we can simply go by the older NICE criteria, where youngish hypertensive patients would receive more, should receive more often ACE inhibitors and ARBs, while elderly hypertensive should receive most often calcium channel blockers and diuretics. And probably the reason is that as you are younger antihypertensive, the probability of cardiac events or cardiovascular events is a little higher, and that they're probably, you'd like to use an ACE inhibitors and ARB who have a little higher incidence, especially if the patient is a diabetic and have got multiple comorbidities in prevention of MI and things like that. But in elderly individuals, when you have more strokes coming up as an adverse outcome, then probably calcium channel blockers and diuretics are better agents. So these agents have got little bit different variations, differences in prevention, various cardiovascular outcomes. And I think age and other comorbidities and the patient factors as a whole do affect our decision making in which drug to choose, or let's say start, because ultimately most of these patients will end up getting 2 or 3 medications, but the initial medications is decided by a number of factors, and age is one of the factors that help us decide, help us making those decisions. Rather, socioeconomic status also um, involves is also involved in taking decision making. For example, we know that calcium channel blockers, these medications have got different economic burden on the patient. We know that the cheapest of these medications are calcium channel blockers, and when we take a look at a diuretics like indapamide, it's like almost 4 to 5 times the cost of calcium channel blockers. So if I have an elderly gentleman, we know that diuretics and thiazide-like diuretics have got much better outcomes for stroke prevention. So, but then I would go for, if a patient has to use for hypertensive medication over a long period of time and he belongs to a lower socioeconomic strata, it will be calcium channel blocker would be my choice, and I would not go for medications like an indapamide medications, and thiazide and chlorthalidone would come somewhere in the middle. So both economic, socioeconomic factors and age factors and the overall patient profile do influence our decision making as a choice of initial therapy of antihypertensive agent, although we have to understand that most of these patients will go on for a 2-drug or a 3-drug combination as their life progresses.
I think, Rishi, you really answered that question very well, and you've given us an insight. As you know, Lionel OP would always tell me what is the most important thing in blood pressure, and he would say the most important thing in blood pressure is to control blood pressure. So that is, I think, the most important thing is to control blood pressure. And you mentioned that calcium channel blockers are available, especially amlodipine is available quite cheaply, and can be used for control of blood pressure in both the elderly as well as in not so elderly people. I think it makes a difference. Age also makes a difference. Younger people, we may think of using ARBs and ACE inhibitors, except for young women who may be in the pregnancy age group where we may hold back from ACE and ARBs. But otherwise, we would, some of these diuretics, as you mentioned, indapamide, can be pretty expensive. So, I think we've got a correct, perspective over there. And so we'll go on to the next, area where we are going to look at this multidisciplinary approach, a diagnostic flow chart, which came up from a paper in India, which was published as late as May 2020. So when you have patients who have uncontrolled hypertension, I think most of us today would also look at, cardiac renal abnormalities, sleep apnea, hyperaldosteronism, and I would also add one more, thyroid abnormalities. We see a lot of women, especially, who have abnormal thyroids, hypothyroid mainly, and sometimes hyperthyroid. Clearly, investigations of weight, waist-hip ratio. I always screen for microalbumin in my patient. Would certainly look at HbA1c. Echo is a must, I think, in every hypertensive patient, because if you see LVH, you're clearly looking beyond hypertension. You're already looking at structural heart disease. The urine analysis, especially the potassium, is pretty important for me. It gives me an idea about hyperaldosteronism. Reading potassium levels is important. Looking at blood sugars and lipid profiles, and the 3 in 3 principle, inadequate blood pressure control with 3 drugs in 3 weeks. Of course, I would stretch that out a little bit and say maybe 3 drugs over a period of maybe 6 weeks. And sometimes I would certainly say that the drug should include a diuretic, and sometimes looking beyond, I would say maybe spironolactone may have to be added as the 4th drug. But having said all that, the questions come up that how do we start our strategies these days? Do we start with a 2-drug pill in most patients, in a single pill, or do we start with 1 drug and titrate up? And so for this question, I would ask Dr. Viveka Kumar, whom I will introduce first. So, sir, can you just share screen with me? Dr. Muchala, Samir, can you just share screen with me so I can introduce Dr. Viveka Kumar, who's also well known to me. Can you just, yeah, that's it. He's been the senior consultant interventional cardiologist and electrophysiologist at Saket in Delhi, the Saket Max Super Specialty Hospital. He's got his FACC and FESC also. He's had multiple research publications in many journals, very involved in electrophysiology, which is important in our country, and multiple awards for his efforts and for his recognition in clinical work. So Viveka, the question is, as I pointed out to you earlier, is does it make sense that we now use different strategies differently from before? Are you still sticking to monotherapy and then pushing up, or are you going with a dual or triple drug therapy?
Yeah, so good evening, Dr. Brian Pinto, for the kind introduction. And, as the not only the evidence, but also the guidelines have now come up, and that says that we don't have to start with monotherapy and go to the maximum dose and then go to the next drug. Now the guidelines also, if you look at the ESC guideline and the other hypertensive society guidelines, that says that we can straight away go to the dual therapy, and then the second step would be the go to the triple therapy. So I would say that the bottom line is, as it has been discussed so far in this meeting, that we need to control the blood pressure to a target level, and that is how we can decrease the end organ damage, decrease the cardiovascular event rates, and also the better you control and don't wait for very long and slow escalation. So we need to so that is why it is better to start with dual therapy, so that you have the best of the both drugs, and you don't need to go to the highest possible dose of each drug as the previous strategy used to be. And if you look at the algorithm of escalation, there is a very early on that the triple drug therapy is also next logical step after initiation with the dual therapy. So I would say that the evidences and the guidelines now say that it's better to go with the dual therapy, and then early on the next step would be the triple therapy. And the drugs which can be used, as Dr. Rishi has also said, that we can go with ACE and ARB with the diuretics. And the second step would be any of these combination. You can add amlodipine, but it all depends on what stage of hypertension our patient has come to us, because in our country, more often than not, hypertension is considered to be part of the aging process, and people don't really get convinced. And a lot of people would say that the guidelines are not there. This is we are feeling absolutely fine, and that's the reason why it is said that hypertension is a silent killer, because it does all the damage before the symptoms would come to the patient. So we need to, make our patients understand and then show the data, because unless we show that what is the evidence is there and what is the importance of dual therapy, because with the dual therapy, the achieving the target and keeping the patient into the controlled blood pressure zone. So if you look at the data in Indian patients, there is enough data that patients, unawareness about their hypertensive status is very high. And second, that those who are even taking the medications within the therapeutic zone, a lot of them are not there. So in the target zone where the blood pressure should be, that is also not achieved. So when you use dual therapy, that more often than not, they'll be in the target zone. And of course, on the follow-up, if they don't, come into the, acceptable target zone, then we can go to the triple therapy. So that is my answer to this question. Would be over to Dr. Brian Pinto.
Thank you, Dr. Viveka. Actually, you brought out this very well, because clearly now we realize that more than 80% of patients require at least two drug therapy, and controlling them with two drugs in smaller doses than rather than giving them a single drug and then waiting for some time, adding something on, is not the way to go, as the guidelines also have pointed out to us. And I think we achieve much easier patients' compliance is better with a single drug therapy. And therefore, I think the best way to go forward with it is to look at, the situation. You can also see in the various...
Pinto, I just wanted to share the poll results. 93% said that they would agree with monotherapy change to double or triple therapy. We just missed out on the previous question also, where 70% said socioeconomic and factors are important.
Let's finish with this one first, since it is...
Sure.
Let's go to this poll first. Yeah.
93% say they would change from monotherapy to dual or triple therapy.
Means they're saying that they would not start with dual therapy.
No, they would. They would. The option is yes.
They would start with dual therapy. So I think that's the correct option that they're going with, and I think that is quite clear that this option would be the best option. You get better results, as you can see. Now you want to go back to the previous question and say what the poll result was there.
Yeah, 70% say socioeconomic and age factors do make a difference in treatment strategy.
Oh yeah.
70%.
Okay. So I think Rishi was also right when he said that, you use calcium channel blockers more frequently sometimes, though you may prevent stroke more frequently, or you may prevent congestive heart failure more frequently by using a diuretic. But so in our country, where we have people who also would have to take it over, lifetime, and where money makes a difference, you certainly would, look at situations where now, this is the ABCD line of therapy that most of us use. And you can see that in all patients, we are either using ACE, ARB, beta blocker, so calcium channel blockers, and diuretics. However, beta blockers have gone down to the fourth line now in a large number of patients. But I believe that after you looked at the India Heart Study, and I'm going to ask Tiny a question over here. Tiny, when we looked at the India Heart Study, the heart rate was somewhere above 80, correct?
Yeah. Yes, 83.
83.
83. Yes, mean heart rate was 83.
Is there a role for beta blockers in our Indian patients?
We just don't know, but all the studies that we had in India, all the studies had shown that Indians have a faster heart rate, and the average heart rate in India Heart Study was 83. So one concept would be that yes, we are sympathetically driven, and we might actually benefit with beta blocker, suggesting that perhaps unlike the ESC guideline where we have pushed beta blocker to fourth choice, we might have to upgrade it for Indian population, bring it forward. In fact, there is a point there. Yeah, there's a point there because, for example, if you take in Kerala, we see a lot of these IT fellows, IT young boys who are young, but then they're very anxious. They come with tachycardia, they have tremors, they're extremely project bound, and they're stressed out. Give them a very small dose of selective beta blocker, and they bless you with their life. Whether blood pressure goes down, whether cardiac event comes down, we don't know because their per se cardiac events must be very low. But they come and tell you, "I feel so fine, doctor."
Their blood pressure comes down. No, their blood pressure comes down. Their tachycardia comes down. So we may have to have our own data because much of the beta blockers were maligned by the fact that the atenolol was used in comparison initially with losartan, and that showed that the benefits. And then, of course, you looked at all the data, and then you looked at beta block. But I think beta blockers in so many subsets of patients where you have associated side effects, associated comorbidities like coronary artery disease, and you have sympathetic over discharge and all. Beta blockers may actually not be so badly put to the in such a bad context as they should be. And in dual therapy and things like that, maybe it may be a good choice. So let's call to action the challenges now once again, Shaumitra Kumar, and the challenges to control uncontrolled hypertension. Which population group is most difficult? Is it CKD or CKD with diabetes, cardiac illness, elderly patient, young patients? Where do you find your greatest difficulty, Shaumitra?
Yeah, if you are talking of the numbers, I mean, bringing down the blood pressure in terms of numbers, the most challenging group is, of course, CKD. I mean, I think all of you would agree that
I agree, CKD.
And higher the grade of CKD, more difficult it gets to controlling blood pressure down to the targeted level. And especially in stage 4 CKD and stage 5, where people are on renal replacement therapy, people have their blood pressure shooting up the day before dialysis, and on the day of the dialysis, it crashes down. So these are peculiar problems with CKD. And then CKD without any cardiac illness is also very difficult to envisage because many of these patients have associated number of comorbidities and cardiac dysfunction and other problems of heart failure. So this is a very difficult group, and a big chunk of so-called refractory hypertension have chronic renoparenchymal or renovascular disease. So I mean, this I would say on paper the most difficult group. But having said that, each category in this list has its own special problem. Those with cardiac dysfunction, I think you are talking of coronary artery disease and patients with heart failure. Now, CAD, of course, there are some compelling indications to use beta blockers or RAS blockers, especially ACE inhibitors. Heart failure, again, beta blockers, ACE inhibitors, and MRAs are compelling indications. But many of the patients in heart failure actually have a low blood pressure. So that is another kind of problem. Uh, and elderly patients have their own problems in that they have more greater propensity for orthostatic hypotension, more propensity to dyselectrolytemia. While you trying out to bring down the systolic blood pressure, diastolic blood pressure goes below 70 or even 60 millimeters of mercury. They are generally very frail, very prone to fall. So these are other problems with elderly. And younger patients, another problem, motivational problem. Now you have to make someone understand in his 30s or 40s that you have to take medication lifelong. So they are the problem of making them understand that they have a problem and they have to continue lifelong without interfering with their lifestyle, their energy level, their sexual function, other things is the problem. And in this group, if you can demonstrate that they have some kind of objective evidence of target organ damage, be it left ventricular hypertrophy or microalbuminuria, I do one thing like pulse wave velocity and vascular aging of the patient. So if you can demonstrate that the patient has something abnormal, it tends to motivate the patient. So each of these 5 categories has its own problem. But as a group, if you ask me, then CKD
Yeah,
with particular comorbidities is the most difficult group.
I would agree. So let's have the poll results over here. Samir first, before I forget once again.
Yeah.
Poll
So
results come out.
45% of the delegates suggested CKD with diabetes,
Yeah, I think
followed by 19% voting for CKD, 15% voting for cardiac illness, 11% for elderly, and 7% for young patients.
so. Would say 65% have voted mostly for CKD and CKD with diabetes. I would put them together. Many times CKD has died, and I think that what Shaumitra brought out is the most this thing, because these are the patients who actually, in my opinion, also, and we have to go beyond the class of drugs which we have suggested over here. We have to go sometimes to centrally acting drugs. Like we have to use drugs like moxinidine. We have to use drugs like
Clonidine.
old drugs like
Clonidine.
yeah, clonidine and all these kind of drugs to bring down the blood pressure in these groups of patients, because they don't react only to the class of drug that suggested.
Yeah, Dr. Brian, I missed one point. If I can have 30 seconds. Now, in diabetes and CKD, another problem is many of the diabetics have type 4 renal tubular acidosis. So hyperkalemia is a particular problem, even in stage 3 and stage 2.
Yes.
So often with use of RAS blockers, you
Yeah.
will find that the patients are developing hyperkalemia.
Yeah,
So
yeah.
that precludes the use of RAS blockers in them. So
Correct.
that can be another problem.
Some of them, in some of them, you can use it. I think maybe a new drug, even ARNI, may be helpful in these group of patients. We must, of course, look at potassium, because potassium will be a problem. So I think what you brought out is a in elderly patients, sometimes orthostatic hypotension does not allow you to treat the hypertension properly. Some of them have hypertension, but they develop orthostatic hypotension when you start treating them. And that sometimes I find as a difficult problem. And there sometimes beta blockers help me to reduce orthostatic hypotension. Young patients, by and large, are not difficult as far as I'm concerned. That what Tiny brought up was a very good point, and I think this question was very well answered. Here are the guidelines to say that in most patients we are trying to get blood pressure down to about 130 by 80. Of course, recently again the Europeans have said that 140, but it keeps on fluctuating. But I think we have now more or less stuck to the goal of 130 by 80, except in the very elderly patients where we may still think that about 140 by 90 is acceptable. These are the various other guidelines that are there. ESC, ESH, you're looking at 2-drug therapy, you're looking at BP goal. You basically like to bring the BP to less than 130 by 80. In most of the situations, you can prevent strokes by that method also, but you won't want to drop it much below that. And therefore, my next question is to Dr. Venkatesh and the poll. What should be the ideal BP threshold in the Indian setting to start pharmacological treatment for BP reduction? That's a very important question to be answered. This is 120 by 80, 130, or 140 by 90.
Yeah, I think this is a question which opens up a Pandora's box, because you will be looking at the Indian setting in context to the European setting and the American College of Cardiology setting, the SPRINT trial, the HOPE trial. And for academicians, it's really mind-boggling because each of them tell us a little different story when you look at the SPRINT trial and the HOPE-3 trial. But having said that, I think the Indian guidelines are now slowly becoming a little more stringent, and they'd say that in most cases, it is preferable to start the pharmacotherapy once the blood pressure is more than 140 by 90 in most situations. That's what the Indian guidelines are recommending. But then having said that, a word of caution, if you have evidence of coronary artery disease or heart failure in any form, including atherosclerotic cardiovascular disease, then it is better to start pharmacotherapy when the blood pressure goes beyond 130 by 80. And here we are in sync with many of the Western guidelines as well. It's important to understand that lesser number of patients need to be treated as far as secondary prevention is concerned. So when you're looking at a secondary prevention and aim at a figure of treating and starting the drugs when the blood pressure goes by 130 by 80 and more, well, it's acceptable and in line with many of the Western studies. Here, I would also like to add that if we use a risk calculator, a ASCVD risk calculator, and punch in the details, and if the 10-year risk is more than 10%, even in primary prevention, it is better to treat these patients when the blood pressure is more than 130 by 80. Of course, we have to be a little careful in elderly people. Like Dr. Tiny Nair said, it's important that we should individualize treatment in elderly people. Probably we could aim for a systolic blood pressure between 130 to 140 and a diastolic pressure somewhere between 80 to 85. Although the SPRINT investigators would not be happy with my statement because they are looking at more stringent control of blood pressure even in elderly. This opens up a little bit of debate. I think the other panelists also can come in and probably either...
let's take the poll first. What did the poll say, Samir?
43% of the delegates, which is the maximum, believe it should be greater than 140 by 90, followed by 30%, which says greater than 130 by 80, and 26% of the delegates feel it should be greater than 120 by 80. So the maximum, think greater than 140 by 90.
I would go with that, what they said, 140 by 90 for pharmacological therapy, because I think that you have, before pharmacological therapy, you have other therapies also. So I'll just call in Rishi Sethi over here, and ask him, what does he think that 140 by 90, because I think at 130 by 80 or above 130 by 80 and below 140, I would first start with other forms of therapy. And Rishi, what would be your take on that?
Yeah, I think as Dr. Venkatesh himself pointed that there are a lot of gray lines that we have to think over. And for the initiation of pharmacological therapy, since hypertension is a mass problem and whatever statements we make will have mass outcomes, I think it is much more rational to initiate therapy only when the blood pressure is above, pharmacotherapy above, when the blood pressure is above 140 by 90. The real question is that what is the target that we are looking at it's actually? And apart from the age where we should not be very aggressive in controlling blood pressure for the sake of preventing of hypotensive symptoms and falls and injuries, it's also one factor also plays in my mind, and that is how frequent is this person going to be in my follow-up? How much religious he would be in coming to my outpatients for a review of the blood pressure. If the blood pressure review is happening more frequently, and if we are more attentive to the patient, if the patient is very aware and more like a SPRINT patient, where then we can think of being a little aggressive in terms of lowering the blood pressure more as an ultimately the goal of target of blood pressure therapy. But if the blood pressure, if the patient is just going to straight the treatment from me and then would be lost to follow up for 2 to 3 years, continue that therapy at home, I would not be very aggressive with the therapy. So the question, to put it in, yes, sir.
Yeah, so I think basically what you stated over here, Rishi, was very clear that you would start pharmacological therapy above a blood pressure of 140 by 90, and then try to go to a target of 130 by 80 or even lower, depending upon how the patient would follow up with you and avoid falls and things like that. And I agree with what you said, and I think there are certain gray lines that we have, but certainly we wouldn't like to target everybody to one at pressures above just above 130 by 80. I don't think most of us start pharmacological therapy. Now, I'm just taking you through. We're running out a little bit of time, so I'm going to be a little faster. The calcium channel blockers have clearly in the guidelines come in, and amlodipine has been the one that we've tested most frequently. It is most widely used of the antihypertensive drugs. It is very often combined with others, and it has shown beneficial effects. So the question is now to Dr. Tiny Nair, which class of antihypertensive agents would you have the most favorable efficacy to safety profile? And you can see the four up over there, which you've already spoken about, Tiny, but give us your perspective.
I think, see, here everybody, all of us realize that when we talk about antihypertensives, more than the efficacy, first thing should be the side effect profile. Because hypertension is per se a asymptomatic disease. Unlike heart failure, unlike angina, hypertension has
Hello.
I think there would be some internet problem from Dr. Nair's end.
Yeah, I think I can't hear him. So should we just take this forward and say that one other person and me can take it forward? I could say that I would be very happy to say that the efficacy to safety profile is really with calcium channel blockers. Clearly, amlodipine has shown very good kind of efficacy and safety. If you were to ask on the phone, a patient says my blood pressure is 210 by 100, I've not had anything, I'm getting a headache, I can't come over to you, these are COVID times, I would be most comfortable prescribing a calcium channel blocker on the phone. I cannot be as comfortable prescribing a diuretic or prescribing an ACE or an ARB. ARB would be next in my category, but that was the way I would go. And I would take a quick review from the rest. Rishi, what would be your kind of thought, Dr. Venkatesh? Yeah.
I would completely agree with you with the safety efficacy profile is maximally suited with calcium channel blockers,
Yeah,
followed by
I think so. And
poorest with diuretics.
yeah, so let's take the poll on this right now.
Yeah, while they take the poll, I think one other comment which I would like to make is when a junior registrar in the emergency talks to me about an elevated blood pressure
Yes.
and says, which drug shall I give? I feel more comfortable in telling them, okay, give a calcium channel blocker. And it's a worry of your mind. You can.
Yeah, you don't have to know the patient's renal profile or anything else.
You don't
I
need
mean, the safest drug to prescribe.
Not asthmatic. You can easily give amlodipine up front. So let's take the poll right now.
So 69% of the delegates feel it should be calcium channel blockers, followed by 17% who are polling in favor of ARBs, 7% diuretics, and 5% ACE inhibitors.
So clearly, as we thought, diuretic, the next would be ARBs in line because they're also pretty safe in comparison. But I think the calcium channel blocker, especially amlodipine, would clearly go in the first line. So here, Rishi, this is a question. What is your opinion as far as beta blockers are concerned as antihypertensive agents? We've spoken about this, but here are your various options available. Can it be given as a first line drug? Is it given as a first line drug in hypertensive patients who have these comorbidities? Should it be an add-on? Are ARBs, ACE, CCBs, and diuretics sufficient? So here's your call to action.
So if I'm giving these four options, I would first go with option number B, that it may be used as a medication in certain conditions. Having said that, I would like to go back to a brilliant review of beta blockers in JAC by Dr. Shripal Bangalore, who mentions that these were the most commonly used antihypertensive medications till 80s and 90s. But then when critical review of data is done, we see that there is very little evidence for the use of beta blockers for hypertension showing advantage. And most of these trials that were showing advantage were actually trials that had combination of beta blockers and a diuretic. So there was, for isolated beta blockers, and atenolol was the most commonly used drugs. Unfortunately, metoprolol has not been studied so well in hypertension, but atenolol per se did not had great antihypertensive efficacy. At the same point of time, beta blockers per se have got, I mean, numerous numbers of shortcomings in terms of beta blockers in terms of low safety profile. You cannot use them in patients of poor COPD. They are the drugs by the virtue of producing bradycardia. They produce the maximum central aortic pressures. And so things like that. There were many side effect profile as well as sexual dysfunctions, new onset diabetes with the use of diuretics. So beta blockers seem to have the poorest safety profile and the least efficacy in terms of data as to be used as an hypertensive medication. So they would not be in isolated essential hypertensions. They should not be the first line medication that we should be using, except 3 or 4 conditions, as we have already discussed. A person who is a younger, hyperadrenergic kind of state, where we know that it's the adrenaline level that are playing the instance, or the patient who is suffering from angina, post-MI patients, patients of heart failure and atrial fibrillation. There, you may use beta blockers as an antihypertensive with an add-on benefit in other diseases also. Otherwise, in uncomplicated hypertension, it should not be used as a first-line medication.
I kind of agree with what you say, Rishi, and I think that point of young people where they may have a hyperdynamic kind of situation where they are overstressed, as Tiny mentioned. So let's take the poll over here, Samir.
Yeah, so according to the poll, we have 31% in favor of option 2, which says newly detected hypertensive with clinical ASCVD, heart failure, angina, or AF.
Exactly what Rishi said, and so I think that
Yes.
was very good. And we're going to hurry along a little bit now because we're passing 9 o'clock, and you can see out over here that the international guidelines recommend various approaches. You can see that there is different kind of approaches that you can see: office blood pressure, ABPM, home blood pressure monitoring, the guidelines given by the ESC, the ESH, the American Heart Association, bringing it as 2A, 2B. So how commonly we are talking about these various approaches? For example, what would be the ideal approach to diagnose masked hypertension? Would it be an ambulatory blood pressure monitoring? Would it be a home blood pressure monitoring? Or would it be a combination or both of them? This is to Dr. Viveka Kumar.
So this is a very important question, Dr. Pinto, that, the masked hypertension is just opposite of what we call white coat hypertension, where in the office, the blood pressure will be controlled. And if you see out of office readings, so that will be higher. So for that, as we understand that home blood pressure measurement will be very good. And even the 24 hours ambulatory blood pressure measurement would be really good. So if we have to detect masked hypertension, and as it has already been discussed that when you have a dichotomy between the patient's end organ damage parameters and the blood pressure which you are seeing in your office, then you must look for these measurements, and it is equally harmful. So in fact, if the target organ damage has started, if the retinopathy is there, the left ventricular hypertrophy is there, so if all these changes are there and the patient sits in the office and clinic blood pressure is within normal range, then we need to look for home blood pressure measurement, ambulatory blood pressure measurement. So I think the answer is both, and this will unmask. And if you look at the Indian data also, there are also almost 20% of the patients were almost masked hypertension. So I think we'll go for both. So over to Dr. Pinto.
Let's get the story of the polls first, and then we'll discuss it a little bit.
Yeah.
So what do the polls say over there, Samir? Hello? Have we lost you?
Yeah, 62% say both,
Yes.
only 3% say ambulatory, and 4% say home blood pressure.
So I think we have a situation where we could use either one of the two, but ambulatory maybe even better at some points, because home blood pressure can sometimes not be taken well. But home blood pressure can also catch the masked hypertension. But I'd like to ask, besides the dichotomy that was pointed out, who are the patients in whom we should be doing ambulatory blood pressure monitoring? And this, I think Tiny has done a lot of work in this area. So, who are the patients whom we should be doing ambulatory blood pressure monitoring in, Tiny?
Yeah, I think ambulatory blood pressure, now that we have a lot of experience in ambulatory blood pressure, has a lot of indication. Apart from the point we said dichotomy between the
Yes.
target organ damage and the blood pressure levels. For example, a patient whose blood pressure is never getting controlled. He comes and says, Doctor, my blood pressure is always high. So you don't know at what time his blood pressure is high. You want to adjust his medication dosage. There might be one patient who apparently blood pressure is not high, but he has a lot of target organ not damage, but events coming in. So you want to see early morning, does his blood pressure go up? And we today know that he's an risk factor for strokes and myocardial infarction, the early morning blood pressure rise. Does he have that? We also know that the night dip, normally there's a dip at night in the ambulatory blood pressure. Is it dip normal, or is it an hyper dipper, or is it a non-dipper, which carries a much higher risk of developing target organ damage? So we can actually quantify, does he need that? If you want to know, is his blood pressure high during morning or at night? It is not just the daytime, we know that during morning hours, daytime, our blood pressure is all regulated mainly by the sympathetic system. We are all sympathetically charged. But at night when we sleep, it is more of a volume and then RAS activation. So hormonal hypertension. So if we want to differentiate between that, we need an ambulatory blood pressure. So ambulatory blood pressure has opened up a huge, big, opportunity for us to observe something that is there 24 hours. Instead of that 2 minute setting in our clinic, we see the
Does it help also to
whole big picture.
time our medications? Is there a role for giving some medication in the night for blood pressure patients? You know, the night.
Yeah, see, very right. See, at one point of time, we were trying to see that does ambulatory blood pressure tell us as to what time to give medication. But two things have happened. One, all the medication that we use today, ARBs, CCBs, they have all a huge long half-life. So their trough peak ratio is very good. So their effect on peak and effect on trough is very, very good. When we say that a blood pressure medicine is very strong, doesn't mean that it is good. Is not the strength. It is important that the trough peak ratio, so even at the trough and the peak, when we compare them, should be more than 50% to tell us that they are very effective 24 hours a day. So with a long half-life and a good trough peak ratio, it doesn't really matter probably what time you give them. But the recent data, for example, the chrono trial have shown that if you give at bedtime, it seems you reduce much of an event rate, which has always, of course, been questioned. And AHACC have said that the data may not be as good as it looks like on the platter. So we have to see into it. But most antihypertensives tend to work better if we give them at bedtime. But ambulatory blood pressure is a good apparatus to tell us what time would be the best to give a drug.
So I think we have covered up a lot of these areas. Now we have a few questions that are there, and one of the questions from the panel is that to Rishi, the calcium channel blockers that you mentioned have shown good CV benefit in the landmark trials. Are there any other antihypertensive agents to match up to the safety efficacy profile of especially amlodipine?
I mean, that I think we took, if we want to go beyond amlodipine, then it would be the ARBs that would be showing the efficacy to safety ratio a little bit superior. I mean, ACE inhibitors have got more volume of data in terms of cardiovascular prevention, especially in diabetics and high risk individuals with comorbidities. But the side effect of coryza and dry cough makes it a little bit of a limitation for long-term use. Plus, the efficacy in terms of pure reduction of blood pressure in numbers is also a relatively little high with ARBs. So after calcium channel blockers, I think it would be ARBs that would be having the maximum efficacy to safety.
But what about some of the diuretics like indapamide? Let's not talk about the cost factor, but diuretic like indapamide or chlorthalidone, would it also show safety to efficacy ratio patients who are likely to get stroke, patients who are likely to get heart failure, some of the patients who may show some of the risk factors for these, would you say that the safety to efficacy ratio would be good in them?
So diuretics and are an extremely well studied uh, agents for hypertension, especially in terms of stroke prevention in elderly. Chlorthalidone has got the maximum data, but unfortunately, when you look at the safety profile of indapamide would be much superior to chlorthalidone in terms of. But then the data with indapamide is it's not so strong, except in recurrent stroke prevention when used with perindopril in progress trial. The data probably with indapamide, we all agree in our heart that indapamide is a brilliant agent, but it is expensive and it has got a limitation of data. So we cannot club all diuretics as one. Diuretics will be having a little bit of a safety profile in elderlies, giving the electrolyte imbalances and producing hypovolemia, especially in country like ours. We have to use them a little cautiously, especially in we want to escalate the dose of chlorthalidones to the level in which it was used in SHEP trial, then it would really be a problem. But diuretics are a brilliant agent, but I would not say they are quite safe except indapamide. But unfortunately for indapamide, we don't have a large volume of data. So I would still go with this answer that calcium channel blockers followed by ARBs have got the best efficacy and safety profile. And if we want to use diuretics, diuretics are a brilliant agent, but we have to be a little more cautious, especially in the patient population where they have shown maximum benefit, that is the elderly.
Thank you. Dr. Shaumitra, treatment for only high systolic blood pressure in the elderly, where diastolic remains under normal limits. What is your take?
Yeah, I did mention while discussing the groups, I mean, the elderly, I did mention this, that while you are trying to treat isolated systolic hypertension in the elderly, the diastolic blood pressure frequently comes down below 70 and at times even below 60. So that is a problem. And then the issue of J curve comes up. But then you have to start slow and go slow. That is the policy that we follow in the elderly. So you have to bring down the systolic blood pressure very gradually. And often the diastolic blood pressure would take care of itself. Although in some patients you will face some problem, but lowering systolic blood pressure will still remain very important in the elderly population. We have to be a little more cautious in the elderly population, people who have documented critical coronary artery disease, especially left main or proximal LAD. There, the lowering of diastolic blood pressure can be a little problematic. Otherwise, it doesn't really create clinical problems, even if the diastolic blood pressure goes down a little low.
Dr. Tiny, how would you differentiate between pseudo-resistant and true resistant hypertension?
I think this cannot be probably answered in one line. But the first thing to understand is that pseudo resistance and resistance is that the patient is not taking the medicine. Non-compliance is the thing. That is first thing that the physician should think. So the many often what we do is we ask the patient that you've been in the hospital for a couple of days. We're not talking about COVID times, but before that, get admitted and see, give the same medicine, his blood pressure gets controlled, right? So I think non-compliance is the first thing that should come to our mind when we are talking about pseudo-resistance. And of course, all the other things that you have discussed, like hypothyroid, is OSA, or hyperaldosteronism, whatever we are talking about, or maybe cheating on medications, or cheating on salt, or taking NSAIDs or steroids, all comes in. But the first thing should be non-compliance. It's that common. It's that common.
Yeah. So, Dr. Viveka, in severe hypertension, which is better, amlodipine or cilnidipine? These are all questions from the delegates. Huh? So, Viveka, what is your view? Are you gone? Are you there?
Viveka, you're on mute.
You are muted. You are muted.
So I think, amlodipine is far more, potent drug than cilnidipine. So there is no doubt. So in severe hypertension, we will go with amlodipine any day.
I agree completely. I think cilnidipine is a very weak drug in comparison. You need to use it at least 20 milligrams twice or thrice a day to get the same effect as 5 to 7.5 milligrams of amlodipine. And therefore, I don't think that is the drug that we need to take up. Now, somebody asked about obesity and dyslipidemia as part of treatment protocols. I think we have already discussed that. Uh, Somebody wants to know about nebivolol and bisoprolol in chronic CKD. Is there any role for these drugs in chronic CKD for therapy in controlling uncontrolled hypertension? Anybody can take it.
Yeah, I think, most CKDs would need multiple drugs. And of course, beta blockers are one of them. So
Yes.
most CKDs will not get controlled even if you use a CCB with a diuretic. Many of the CKDs you may not be able to use a RAS inhibitor, right? So
Yes.
your armamentarium is less. You might be using moxonidine, you might be using clonidine and whatnot, and obviously beta blocker would come in. So a patient who has a tachycardia and other indications for a beta blocker, certainly beta blockers are good. And when we are using beta blocker, nebivolol and bisoprolol both are good, because for hypertension, nebivolol and bisoprolol almost matches out, and none of them has got a restriction of dosage if the GFR worsens. So you can use any of them.
Yeah, so I think those were most of the questions. I think we have covered up almost everything. Uh, Clearly, it has been a wonderful discussion. Thanks to all of you. Samir, you really got a very good panel. We had very good discussion. Let me hand it back to you after thanking all the panelists over here, Tiny, Rishi, Soumitra, Viveka. If I missed, everybody, all of you have been excellent in discussing these. And Samir, you may be having a video or something to show before we.
Yeah, we'll just play a 1-minute video and then I'll give the final vote of thanks. Mr. Jignesh, can you just play the video, please?
I'm going to make sure, because I'm not sure.
So I think today we had great deliberations on various aspects with respect to hypertension management. I thank our esteemed panelists, Dr. Tiny Nair, Dr. T.K. Venkatesh, Dr. Soumitra Kumar, Dr. Rishi Shetty, and Dr. Viveka Kumar for their vital insights, which not only made understanding hypertension very easy, but also gave a good recall of the theme laid down by World Hypertension League this year, which is measure your blood pressure accurately, control it, and live longer. My heartfelt thanks to Dr. Brian Pinto, who, as always, has been very effective in navigating the discussion in a manner that ensured percolation of key messages to our esteemed delegates. I'm happy to share that we had 4,893 doctors pan-India who have been attending and witnessing our webinar. I sincerely thank you all for sparing your precious time on a Saturday evening and also staying besides our Indian patients during this very trying times. So thank you very much. I request you all to stay indoors, stay safe, stay healthy, and may God bless each one of you. Thank you very much and God bless.
Thank you.
Bye.
Thank you.
Good night.
Thank you very much. Thank you.